Hello, my name is Dr. Carla Devlin and I'm a doctor of across 2 decades. I'm a cosmetic doctor and owner of Berkeley Aesthetics, which is a medical aesthetic clinic in Northern Ireland. The aim of this presentation is to bring you on a journey to understanding the comprehensive approach to how we manage sensitive skin and rosacea and to purposely appreciate the importance of achieving healthy skin. So here we begin with the skin barrier. The skin barrier is formed by the uppermost layer of the skin called the stratum corneum and provides a number of vital functions. Often compared to a brick wall, the skin barrier is composed of interlocking pentagonal comiocytes, which are the bricks, and enmeshed in the lipid matrix of ceramides, cholesterol, and fatty acids, which make up the mortar. Abnormalities in the structure and function of the skin barrier underpin a number of dermatological conditions. It protects against UV light, mechanical, thermal, and chemical stresses. It also restricts water loss from our bodies and provides the ingress of harmful irritants, allergens, and also bacteria. The skin barrier also provides sensation. It has receptors that sense touch, pressure, pain, and regulates temperature. The sweat glands, the hair, the adipose tissue are important for thermoregulation. The skin barrier also supports metabolic activity, with the subcutaneous adipose tissue being involved in the production of vitamin D and also triglycerides. When the skin barrier becomes compromised, we have some issues. Skin inflammation is the immune's response to injury, infection, or irritation to the skin, and it aims to eliminate the trigger, repair tissue, and restore balance. So acute inflammation can be very normal. It's protective, rapid, short-lived, and resolves once the trigger has gone. But when external triggers persist and continuously are allowed to persist and penetrate the skin, then this can lead to chronic inflammation, which can be associated with ongoing tissue damage, nerve sensitization, barrier breakdown, and vascular changes. At a cellular level, the trigger leads to a cascade of events which includes immune cells called mast cells, keratinocytes, and Langerhans cells releasing chemical messengers called histamine, cytokines, and neuropeptides, which in turn causes vasodilatation, which is redness or warmth, increased permeability, which is swelling, and nerve stimulation, which is pain, stinging, or burning sensations. Chronic inflammation occurs when it's left untreated and the cycle intensifies and drives barrier damage. So when the skin barrier is compromised or damaged in any way, it is no longer functioning to its optimal capacity. In order to understand sensitive skin, we need to look at the syndrome of neurosensory and barrier dysfunction. Sensitive skin is a dual syndrome of structural barrier weakness and also neurosensitive hyperactivity. So let's look into this in a bit more detail. Barrier dysfunction, or the vulnerable wall as I call it, is when the skin is disrupted and it becomes thinner and more permeable. Water can escape too quickly, and this then can lead to the skin becoming dehydrated, tight, and more prone to micro cracks, which can cause irritation and sensitivity. The skin barrier relies on 3 essential components: stratum corneum, lipids, natural moisturizing factors, and the acidic pH of the stratum corneum surface. Lipids, especially the ceramides, form the protective mortar holding the barrier together. Damage reduces their production or strips the ceramides away. With fewer ceramides and lipids, the barrier can't repair itself, creating a vicious cycle and compromising the barrier resilience. The skin surface normally has a balanced ecosystem of good bacteria that help protect against pathogens and inflammation. Barrier damage allows harmful microbes to overgrow while reducing beneficial ones. So this imbalance or dysbiosis amplifies inflammation and immune overactivation, leading to sensitivity. Neurosensory hyperactivity is when more irritants can penetrate the skin, which means that the nerves are exposed and neuroinflammation is triggered. The transient receptor potential, or the TRP channels, especially TRPV1, play a significant role. These channels are present on both nerve endings and keratocytes, and when activated can trigger release of neuropeptides like substance P and CGR, causing vasodilatation, mast cell activation, and heightened sensory responses. Some studies show that some inflammatory medications like cytokines and interferon have been detected, mediators like cytokines and interferon have been detected in neurogenic inflammation. So in summary, this synergistic feedback loop involves skin barrier failure, exposes the nerves, and activates nerve-releasing neuropeptides, and it's these neuropeptides intensifying inflammation and sensitivity, leading to a patient feeling sensations of burning and itching. Sensitive skin isn't just about the objective cellular damage to the skin. It is a subjective discomfort response to the stimuli personal to that patient. At its core, it is a syndrome of neurosensory and barrier dysfunction, and patients often describe stinging, burning, tightness, or itching, even if there is no physical signs on the skin. Sensitive skin is becoming more common worldwide and doesn't discriminate and affects all ages. The triggers are wide-ranging, like environmental, pollution and UV, lifestyle like diet, alcohol and stress, psychophysical like emotional stresses, and it's these extrinsic and intrinsic factors that feed into the barrier breakdown and neuroinflammation. So when you think about managing neuroinflammation and sensitivity, it is imperative that we take a holistic approach to the patient by addressing barrier repair and neurosensory overactivity, but also using the biopsychosocial model for our patients. So what is rosacea? Rosacea is a prevalent chronic inflammatory skin condition affecting an estimated 5.46% of the global adult population, which translates to 415 million individuals worldwide, although despite its prevalence, rosacea is still often underdiagnosed and undertreated as well. The exact cause is unknown, but it is thought to have a combination of genetic predisposition, immune system dysregulation, and vascular hyperreactivity, with microbial factors that primarily affect the face. It commonly occurs in adults aged 30 to 50 years old and more commonly diagnosed in women. It is not a curable condition, but symptoms can be controlled. Rosacea is often associated with sensitive skin, which is characterized by burning, stinging, and heightened reactivity. Key features of rosacea include persistent facial redness or erythema, often with flushing, visible blood vessels on the cheeks and nose called telangiectasia, small red bumps or pus-filled spots called papillopustular rosacea, and skin thickening, often on the nose, called rhinophimia in more severe cases. Ocular involvement in rosacea is quite common, with an estimated prevalence of around 50 to 60% in rosacea patients. These ocular symptoms can range from mild dryness, irritation, burning, or redness of the eyes to more severe forms of keratinitis. So the pathophysiology of rosacea. Rosacea patients have an overactive innate immune system, especially in the skin. The key features of rosacea include cathelicidin, which is an antimicrobial peptide, when abnormally processed, promotes inflammation and vascular changes. An overactive tool like receptor 2 leads to increased inflammatory mediator release. Pro-inflammatory cytokines and matrix metalloproteinases are elevated, which is degrading the collagen and disrupting the dermal structure. For vascular hyperreactivity, you have microvascular and endothelial cells more sensitive, leading to flushing and persistent erythema and telangiectasia. Vascular endothelial growth factor, or VEGF, and other angiogenic factors are upregulated. You have neurovascular changes, so dysregulation of sensory nerves with transient receptor potential, or TRP, channels become hypersensitive, leading to the burning, stinging, and flare-ups, which are triggered by extrinsic and intrinsic factors. The microbial contributions is overgrowth of the dermodex mites on the facial skin, which can trigger immune responses. Bacteria associated with dermodex may release antigens that amplify inflammation. And then, of course, you have skin barrier dysfunction. So disrupted barrier dysfunction increases the transepidermal water loss, which leads to dryness, irritation, and increases sensitivity, which perpetuates the inflammation. So how does this translate to patient clinical features? Well, the molecular and cellular changes manifest as observable signs. So an early intermittent phase, or the flushing stage, is transient, facial flushing with triggers. Patients may have burning or stinging sensations. And the inflammatory phase is when persistent erythema develops. Papules and pustules appear, which are acne-like lesions, but without comedones, and early telangiectasia may form. The chronic phase of rosacea is when it has got the visible telangiectasia becoming more permanent, and the skin may even thicken, especially around the nose, and you may then have the ocular involvement that will develop. But it is a chronic, fluctuating, and episodic condition. So if we think about how does our patients present, ask the patient about their main concern. It could be redness, it could be the spots, it could be skin sensitivity or skin swelling, or it could be eye symptoms. You will want to know when the symptoms first appeared and if it was a gradual or if it was a sudden onset. What has triggered these events? Are the symptoms intermittent or persistent? Is there seasonal variation? In terms of the symptoms, is the redness episodic or is it constant? Are the flushing episodes frequent? How long are they lasting? And what are the triggers? Do you have burning? Do you have stinging? Do you have itching or swelling? Thinking about the thickened skin and their eye symptoms and aggravating and alleviating factors. And most of all, the impact on quality of life. It is important to know the patient's previous dermatology history, which includes previous acne, eczema, or seborrheic dermatitis. Any history of flushing disorders such as lupus or the menopause. You want to know about previous rosacea treatments and the response to those treatments. In their medical history, it's important to ask about the gastrointestinal history because there is some evidence that links rosacea to gut disorders such as H. pylori and irritable bowel syndrome. You will want to know what their medication history is, as specific long-term steroids or niacin or amiodarone can mimic or worsen rosacea. In family history, there is a genetic predisposition in first-degree relatives. And of course, ask the social and lifestyle factors. Like I said before, the quality of life impact score is important. The psychological and psychosocial effects can be significant, from embarrassment, low self-esteem, low confidence, and social withdrawal. Depending on the occupation of the patient, it can have an occupational risk and impact, and is associated with higher rates of anxiety and depression. So if we think about our triggers and our lifestyle factors, sun exposure or UV radiation is most commonly and reported trigger. Other triggers include temperature, food and alcohol, emotional and lifestyle factors, and topical and chemical irritants. Other triggers can be hormonal factors like perimenopause and menopause and certain medications. Not every patient reacts to every trigger, so it is key to take a history of individual patterns, encourage patients to keep a symptom and trigger diary, and focus on minimizing exposure. So then if we think about looking at the examination of a patient with sensitive skin and rosacea, make sure that you examine the patient with really good natural lighting. You're looking for the distribution of erythema, which is usually central in the face, cheeks, chin, and forehead, and is usually symmetrical in rosacea. They may be extension from the scalp to the ears to the chest, but this is less common. When you see the erythema, make sure if it is blanchable or non-blanchable by pulling the skin taut. Assess if there's any telangiectasia, which are visible dilated capillaries, most likely going to be on the cheek or the nose. Assess if there's any papules or pustules and ensure that there is no closed or open comedones, which is what distinguishes rosacea from acne vulgaris. Comment on the distribution, and it's usually central, sparring the perioral area, which distinguishes it from perioral dermatitis. You may see phimosis changes or thickening irregular changes of overgrowth, especially in the nose, called rhinophimia, and may even have it on other sites, especially the chin, the forehead, and around the ears. Check the patient's eyes, assess conjunctival injection or watery or bloodshot eyes to see whether the rosacea has been affecting the eyes. Check the eyelid margins because they may be inflamed. Check for signs of skin sensitivity, which is dryness, scaling, or irritation, which may suggest barrier dysfunction. Avoid probing the skin too much, as some patients may find the examination uncomfortable if they're particularly sensitive or tender. And as always, make sure that you check beyond the face, checking the scalp, the ears, behind the ears, the neck, upper chest, hands, and nails. As a clinician, it is important to use clinical photography with patient consent for baseline photos and to document your findings and subtype of rosacea and its severity. So what is with the challenges of rosacea treatments at the moment? Well, as advised before, there is no cure, but we can control symptoms. There are multiple conventional therapies that are available to treat rosacea. Current treatments suppress inflammation, reduce redness, or control flare. However, they do have their limitations. It is a worldwide issue of antibiotic resistance, both with topical metronidazole and oral tetracyclines, because they're not ideal for long-term therapy. Oral tetracyclines are good for papulopustular aspects of rosacea, but is less well tolerated by patients due to the stinging and irritated feeling that they have when they already have sensitive skin. So relapse is common after discontinuation. Topical ivermectin just targets the dermodex mites and has an anti-inflammatory activity and is more effective than topical metronidazole, but can further cause dryness and dermatitis, and it is not effective in the vascular components of rosacea. Azelaic acid is good for papules and pustules due to its anti-inflammatory, keratolytic, and antioxidant effects, but it has a slow improvement over 8 to 12 weeks, and many patients then stop early because of the irritation. Background redness appears to be the hardest symptom to treat, and topical vasoconstrictions can cause rebound erythema. Vascular laser IPL is effective, but it is expensive and requires multiple sessions. So how do we want to have our treatment goals? Well, rosacea is a long-term skin health condition and involves the patient well-being. So we should be thinking about symptom control and flaring of the preventions, reducing erythema, flushing, papules and pustules, and controlling the ocular symptoms, identifying and minimizing individual triggers, and preventing and reducing the frequency and severity of the flares. For protection and repair of the skin barrier, use gentle, non-irritating skincare, encouraging daily broad-spectrum sunscreen, which is critical trigger prevention, and avoid overexfoliation and irritants. It is important to address the vascular and structural changes by managing persistent erythema and telangiectasia and monitoring and treating the phimosis changes early on. We should manage the ocular health by screening routinely for eye involvement, extending lid hygiene, and using warm compresses and lubricants for any eye symptoms that are present. And of course, always referring to an eye specialist if the severe eye symptoms. It is important to also address the psychological and social well-being of the patient, recognizing the psychological burden and often reassuring the patient. Long-term maintenance and relapse reduction is important by setting realistic expectation. Rosacea is chronic but controllable. Use a step up and step down approach, so you have more intensive treatment for flares and gentle maintenance for remission. Encourage patient self-management and empowerment. It is so important for evidence-based skincare, trigger diaries, and adherence to that skincare. The multimodal personalized care is a combination of using evidence-based skincare with in-clinic treatments. And of course, patient education is crucial. And as always, with all of our patients, we advise no use of sunbeds. So then we discuss our holistic approach. What do we need to treat rosacea? Well, skincare products and treatments need to be clinically proven with rigorous testing to be safe, effective, and suitable for rosacea. No test, no claim. Neurosoothing active ingredients should be carefully selected to address the unique needs of sensitive, rosacea-prone skin with the aim to calm, protect, and restore the balance to the skin. The emollients, or the creams or moisturizing creams, should deeply repair the skin barrier, providing intense hydration and soothing properties, and an emollient rich in ceramide and hyaluronic acid is ideal for this. Gentle cleansing is a must for rosacea patients, and the cleansers need to be specific for sensitive skin so as to not strip the natural barrier and reduce the risk of irritation for flare-ups. Active ingredients need to help regulate the sebum production, reduce redness, and maintain the balance of the skin microbiome. Active ingredients need to also achieve an even complexion. Skincare products for rosacea that specifically are formulated to combat the harmful effects of pollution on the skin are important to protect, detoxify, and revitalize the skin. Vitamin C and vitamin E provide antioxidant actions to neutralize the free radicals and protect the skin from daily external aggression that flare rosacea and accelerate aging. A very high SPF protection is key and must protect against UVA, UVB, and blue light. Retinol is a potent derivative of vitamin A and promotes cellular turnover, but its use in sensitive skin or rosacea-prone skin needs careful consideration. So a gentle form of retinol with soothing actions can benefit without exacerbating the rosacea. The liposomal encapsulated of retinol palmitite ensures a controlled release, minimizing irritation. Niacinamide and allotonin are soothing ingredients and help calm any redness and inflammation, and regular use of retinol will improve the smoothness of the skin and improve its elasticity. So what about further future directions for rosacea? We do need a better understanding of rosacea and sensitive skin and the role of transient receptor potential channels, neuropeptides, and vascular hyperactivity. We need to be identifying biomarkers, for example, serums, genetic and microbiome based, to predict flares, treatment, response, and disease course. The role of the skin microbiome is an evolving area in dermatology and across the whole of medicine, and the use of the microbiome targeted therapies like probiotics, prebiotics, and microbiome transplantation is an exciting area of medicine. As it is increasingly exploring rosacea diagnosis, management, and research between skin analysis, phenotype recognition, and early detection. So what are key takeaway messages from this presentation? Barrier dysfunction is not just a symptom of rosacea and sensitive skin. It is a central driver of disease. When the skin is compromised, it amplifies inflammation, alters the microbiome, and heightens neurosensory reactivity. Protecting and repairing the skin barrier is therefore a cornerstone of both treatment and prevention of rosacea. Neuroinflammation is central to sensitive skin and rosacea. It explains the stinging, the burning, and exaggerated flushing, and overactive nerve endings in neuropeptide release fuels vascular instability, irritability, and inflammation, making neurosensory modulation just as important as anti-inflammatory treatment in its management. Barrier and nerve calming therapies and strategies are absolutely key. Treating rosacea and sensitive skin needs ingredients that not only repair the skin barrier but soothe the neurogenic inflammation, restoring comfort and resilience to sensitive skin. Skincare should focus on 3 pillars: repair the skin barrier, renew through evidence-based skincare, and gentle evidence-based treatments and restorative of skin comfort and resilience. And these principles bring both clinical improvement and long-term skin health. Managing sensitive skin and rosacea requires a holistic approach that addresses barrier repair, neurosensory calming, inflammation control, and lifestyle triggers which support the emotional well-being and patient confidence. It is absolutely and utterly our job as clinicians to listen, to respond with intention, and our aim is to calm, renew, and restore patients with sensitive skin and rosacea. Thank you very much for this presentation.